Good morning, everyone. Today I'll present my case from cloudiness to clarity, a case of untreated endothelitis and its resolution. So the crumbling shield, how stromal keratitis breaks the epithelium. So persistent inflammation or stromal degradation causes the weakened stromal support, leading to disruption of the epithelial adhesion. Consequently, there is a direct endothelial damage due to the inflammatory cells that lead to endothelial pump failure, causing corneal edema that finally leads to the epithelial defect. So this is the case history. 62-year-old male presented with pain, redness in the right eye since 10 days. His BCVA was 6/18 parts in the right eye, while the left eye was normal, 6/6. In clinical findings, there was localized ciliary congestion from 6 to 7:30 o'clock hours with epithelial defect 3 to 4 mm size, 2 mm inside the limbus that was extending from 6 to 7:30 hours. There was localized fine irregular white KPs on the endothelium and the anterior chamber was quiet. And the posterior segment examination, there was no abnormality detected, while in the left eye, the anterior and the posterior segment was normal. So the probable diagnosis was made immune-mediated stromal keratitis with the loss of epithelial integrity. But which autoimmune disorder was responsible for this? So the culprit resided in the past history. Patient was a known case of psoriasis vulgaris and was on methotrexate 15 mg per week dosage since last 15 years. So the management that we did was he was given steroids as well as the antibiotic and the hometropine along with the lubricant and was followed up on the day and the dermatologist review was advised. Then on follow up in the day 1 review, symptoms improved with vision improvement to 6/18, and on day 7 review, the symptoms as well as signs improved with best corrected visual acuity improved to 6/9. But on 3-month visit, there was a recurrence and that strengthened our diagnosis, where patient again complained of pain, redness, blurring of vision in the right eye since 10 days, and clinical findings were epithelial defect at the same location with stromal haze and thinning, and no dermatology review was done, and he had already stopped methotrexate since last 20 days. There was no AC reaction, hypopyon, or the corneal sensations were intact, and the endothelial KPs, they were persisting. So this is a case of recurrent keratitis at the same location with KPs persisting, diagnosed as chronic endothelial inflammation, immune mediated due to the psoriasis. So our differential diagnosis that was, it was not infectious keratitis because there was no ulceration or there were no infiltrates, no necrosis, stromal necrosis or ghost vessels, and while the AC reaction was no AC reaction was present. It was not marginal keratitis, neither a case of neurotropic keratitis or interstitial keratitis. While our favored non-infectious immune mediated because it was strong association with the autoimmune disease like psoriasis, and it responded to the steroids, and since there was persistence of KPs, we diagnosed it as endothelial dysfunction that happened over time. On literature review, psoriasis and keratitis, it has been found that ours was a rare case report of stromal keratitis associated with psoriasis. The literature that proved was psoriasis associated keratitis, analysis of densitometry and comparison of corneal biomechanical properties and ocular changes in patients with psoriasis. So the key takeaways from the case are: autoimmune keratitis in patient, dig deeper into the history, consider psoriasis as a corneal disease, it's not just a uveitic one, and endotheliitis can be slow, silent threat, so consider doing specular microscopy, and consider early diagnosis as long-term sequelae can lead to irregular astigmatism or low vision requiring rehabilitation.
Thank you. I think you have already crossed the time.